Hey guys, in this video, I'm going to talk about coronary artery calcium scores or CAC scores, which have become very popular to get these days. But we're going to talk about what they actually mean and how they actually increase risk of a heart attack and what to do about them to make them irrelevant, right? So let's get started. Now, um, most people, they go to the doctor and they're told they have a high CAC score. They get this test and they're told they have a high CAC score and that they're told that this increases their risk for heart attack. And that's true, right? The studies are very clear that having a high amount of calcified plaque in your arteries increases your risk for a heart attack. But the most important question is why? Because if you don't understand why that is, then you don't understand what to do about it, right? So when we put the research together, you start to realize that this test, like a CAC score or any test really, is not really what determines your risk of something. The environment you put your body in is much more important, and the health behaviors that you do are much more important than what any test says. And hopefully that will become clear to you by the end of this video. So, a coronary artery calcium score, it's a CT scan that they do to look at the amount of calcified plaque in someone's arteries. And so, if you look at the research, it's very clear that, the higher the CAC score is, the more risk of heart attack there is. So you can see here in this chart from this study, anybody's score above 100, you're increasing risk, 100 to 300, more risk, and then above 300, you're at the highest risk. And the higher that number goes, the more risk there is, right? Now, first off, considering that a higher CAC score, it means more risk of a heart attack. I find it concerning that one of the main drugs used by cardiology, which is statin, cholesterol-lowering medications, have been shown to increase the amount of calcified plaque in the arteries of the heart. And there's many studies that show that. Here you can see this one here that I'm putting up. Shows that people who took statins had an increased risk of calcified plaque. And so, they'll argue that the calcified plaque, it means that it's more stable, right? It's the hard plaque. And so it's not going to have a plaque rupture and cause heart attacks. However, the issue with that I mean, at this point, I've asked many different interventional cardiologists when they go in, someone's having a heart attack and they go in to place a stent or intervene or whatever. I've asked them when they find a blockage or they find whatever they find in there, like what tells them that it was a plaque rupture that caused the heart attack, and none of them can really give me an answer. I've heard answers as to basically it's inferred, right? It's the theory that causes heart attacks, and so that's what we infer happened. I've heard them say that you could do like ultrasound stuff, or there's studies that use ultrasound. They put ultrasound in the arteries, and it gives them an idea of more damage or more newly clotting formation, but there's still an assumption that it was a plaque rupture. Conversely, there's a paper here called The Myth of the Vulnerable Plaque, which reviews all the evidence for the plaque rupture theory of heart attacks. And it basically found that plaque ruptures happen very often, but they rarely cause heart attacks. So they can happen and they can lead to the more development of plaque, kind of this rupture that happens and heals, but it very rarely causes a heart attack. Their number in this was that given all the risk for any one plaque, the risk for any one plaque of causing a rupture and causing a heart attack, or that rupture causing a heart attack, is 0.06% per year, which is essentially almost never. So yeah, to me, there's no argument to, hey, we want to increase the amount of calcified plaque with a statin drug. That's a good thing because it's like, what do you want? Like, if you increase the amount of calcified plaque, it shows the increased risk of a heart attack for more calcified plaque. But you're saying, yeah, but if we stabilize it, it decreases the risk of heart attack. And it's like, well, which one is it? That doesn't make sense. It's not really matching up. And to me, there's really no evidence for the plaque rupture theory causing the majority of heart attacks. So yeah. Now, again, while the research shows that increasing CAC scores increase risk of heart attacks, it shows that people with a score of 0 still have a chance of a heart attack. So a 0 score, there's a 1.1 to 1.7, according to the study, percent chance of having a heart attack. And so I like to tell this or make this analogy all the time. 6 months prior to my heart attack, my CAC score was a perfect score of 0, and I still had a heart attack. And I was metabolically healthy and low inflammation and all these things. Conversely, I've had clients that have come to work with me. One guy had a CAC score of over 3,000, which is astronomically high. But this guy was in his 80s and never had a heart attack, never had heart disease symptoms, and was living his life the way he wanted to. So, despite this very high number, he never had an issue. I actually know somebody who has a CAC score at this point of 5,600. And again, he's never had a heart attack, never had heart disease symptoms. So, what I'm trying to say here is that this number doesn't really tell us the whole story. It's information. It's important information that we can gain and see where we're at. But this number doesn't really assess our risk, because people like me have a score of 0, they can have a heart attack, and people who have really high amounts are at increased risk, but some of them don't, right? So what's the difference there? What's the factor that makes the difference? So heart attacks can happen with no calcified plaque, and they rarely happen from plaque rupture, which suggests that this increase in calcified plaque score, there's a different mechanism by which it increases the heart attacks, right? So what could potentially be that mechanism? And to me, what that mechanism is that, you know, it's the disruption of blood flow created by this plaque, because the plaque is growing inside the artery wall, and that's creating an issue here with the blood flow. Ever seen like water flow past a rock in a river, right? And it kind of eddies on the other side. So we're creating turbulent blood flow. And so that same study that we talked about, the myth of the vulnerable plaque, they said that the vulnerable plaques aren't causing many heart attacks. And when we try and treat the plaques, so when people get stenosis and buildup of calcified plaque and it creates this stenosis, the research is pretty clear that if we try and treat that with a stent, it doesn't actually prevent future heart attacks. Why? Because the stenosis of the arteries is not what causes heart attacks. One thing that can cause it is this acute clotting mechanism. And so what in that study where they assessed the risk of plaque rupture and causing heart attacks, and they assessed it as small, they say we should be focusing on thrombosis promoting risk factors. Those are the things we should be looking at as far as what creates risk. Because if we have this stenosis of plaque in there, and we also have an increased risk for clotting because we're inflamed, or we have very sticky or viscous blood, or we're dehydrated or things like that, those things can make that disruption in blood flow more likely to cause a clot. And the studies show this. Studies have shown that our plaque in arteries is actually made up of clotting tissue, but studies have also shown that interrupted or turbulent blood flow is one of the biggest risk factors for the development of clotting, like acute clots that can cause strokes and heart attacks, but also of arterial plaque. And there's many studies that show that. So really this clotting risk is the bigger issue. And after all, like if you go to the hospital with a heart attack, they're not going to go in there and administer cholesterol busting enzymes. They're going to administer clot busting enzymes, right? And then they're going to try and open up that clot and everything. So, and I talk much more about the mechanisms of that and everything in my lecture on heart attacks. But so yes, it's the interrupted or stagnant blood flow, this thicker viscous blood, or blood that's stagnant, or blood that is turbulent and kind of moving around and creating turbulence in the area where it shouldn't. It should have this laminar flow, and it's creating turbulent flow. That's why a CAC score increases the risk of heart attacks, because that can lead to it's more likely that a clot could form if we have this plaque in there and we have this viscous blood and these from thrombosis promoting risk factors. So that's the real reason the high score promotes the increased risk of heart attack. And the other evidence for this, for me, is that there's research that shows that exercise, just being active, mitigates the risk of having a high CAC score. Now, why would that be? Well, because people who exercise maintain better blood flow, right? And so we're maintaining this blood flow, mitigating the risk of this plaque that's creating this turbulent blood flow, or keeping blood moving better. Further, exercise has also been shown to increase the robustness and the activity of formation of collateral arteries. So if, Dr. Giorgio Beraldi, who is a forensic pathologist, found that anytime a blood vessel got to about 60 or 70% narrowed, that the body would build collaterals around it. Cardiologists have told me that some people have collaterals, some people don't, but Beraldi's work, which he autopsied thousands of hearts throughout his career, he never found a heart that was 60 or 70% narrowed of an artery that didn't have robust collaterals around it. So it suggests that everybody does form them, but insulin sensitivity and exercise are what stimulate more robust formation of collaterals. So that's why exercise may mitigate the risk of a high CAC score as well, because it creates blood flow and it encourages the production of collateral arteries. So if you do get this stenosis, it goes around. So I guess my main point in this is that, it's because people come to me all the time like, hey, can you reverse plaque? And like, technically I did in my leg. But that I think was soft plaque, right? Because there wasn't enough time for that to calcify. It wasn't there long enough. People always ask, well, can I reverse calcified plaque? And I would say that I've seen people do it. I've seen it happen, but I can't guarantee anything. But I would say that the goal is not necessarily to make that plaque go away. It's to make it irrelevant, right? It's to make it irrelevant by creating adequate blood flow, and increasing collateral so that even if it stays or gets worse, that it never causes an issue and you end up being that guy in his 80s who had this high score, but it never causes an issue. You can do everything you want in your life. That seems like a more appropriate goal. And if the plaque does regress, that's a bonus, right, from the things we do. And so maintaining adequate blood flow seems to be the thing that will mitigate the risk of a high CAC score, keep blood moving through these tight spaces, and build the formation of collaterals. And so exercise is one way to do that, like we talked about, but there's many other ways to do that as well. There's plenty of other research that shows that sunlight, infrared sauna, red light panels, grounding, hydration, having good metabolic health, regular cold exposure, all those things can maintain adequate blood flow. And that's what I teach people in my 12-week heart health mentorship program, is how to do those things, how to optimize those environments, and more in depth of why those specific things are creating this blood flow, which has to do with structured water and things. So yeah, if you want more information, then obviously you can keep following me here on YouTube, keep subscribing, or follow me on social media. But I also have the 12-week heart health mentorship program. So if you're interested in that, click the link in the description of this video, to learn more information about that and maybe book a call. But stay healthy out there.